the TB infection may be unmasked because of the antiretroviral therapy, and that their status has been unmasked and they are benefiting. So the recommendation based on the evidence is that, particularly because so many of our patients are now on antiretroviral therapy, and the evidence suggests it doesn't matter whether they have a positive or negative test of infection, we need to treat all of them. So I think the HIV-infected individuals are clear. The children less than 5 are incredibly high risk of TB. And we know that in certain settings that can get up to, particularly the less than ones, up to 7% per year. That's higher than what we saw for HIV not on antiretroviral therapy. So they are exquisitely sensitive to developing TB. And again, the risk is so high, just treat. So what about household contacts older than 5? Because that's the group that we're worried about. Avinash presented the guidelines, and he made it a bit more categorical. Actually, the guidelines are ambivalent. So it does, in some places, say you must test, and in others, it kind of gives you an out. So that's the current guidelines. But when you look at the evidence of household contacts in high burden settings and even outside of high burden settings, and we've just completed a trial and we've submitted this for publication of household contacts in 10 high burden countries. These were contacts of MDR TB, which, you know, it's likely to be similar for drug susceptible, or even more so for drug susceptible TB, if you believe that MDR TB is less transmissible. But of the household contacts, so spanning from Latin America, Sub-Saharan Africa, India, and Southeast Asia, about 10% of household contacts were less than the age of 10, and we heard some evidence to support that today. I think it was from Kenya. About 10% were HIV infected, and of the remainder, 80% had TB infection. So when you take this all together, 70 to 80% of all household contacts have an indication for treatment. And so if we're going to say we want to test the household to see who's going to benefit, well, you're going to test everyone to treat 80% of your household contacts. So from a public health perspective, countries need to ask, is that of benefit? Or should you take a public health approach and just, when going to a household, treat everyone, either for disease, because when you screen them, you identify those with active disease, or you treat them for infection. So that's a public health approach. And this is something you would need to look at in each country. There is quite a lot of discrepancy. There were countries with lower rates of infection, but not many. Honestly, for the most part, it was very high. So certainly I would advocate not worrying about it. Don't let it be a barrier, because we've seen that in resource poor settings, high burden settings, requiring a test of infection is a barrier to scale up. And I can use South Africa as an example. We had it initially as part of the guidelines, and we saw very, very little uptake. We then took TST out of the guidelines, and uptake started to soar. We then put it back in because of the requirement for lifelong preventive therapy, and then requiring a test of infection. And basically, it still wasn't being done, largely because of availability. But we still continue to implement, but without that test of infection. So what's important is scaling up preventive therapy. If you have the resources and you have the capacity to do the test, then by all means do it. But otherwise, don't let it be a barrier to scale up.
Thank you. Do you have a recommended dose adjustment of the rifampicin when we use together with dolitic therapy, and dose adjustment of rifampicin or rifampicin in 3HP when we use together with EPAM?
No, so we don't have to dose adjust the rifampicin. That will remain the same. It's whether we have to dose adjust the dolutegravir because of the drug interaction. So the results from that safety and PK study will become available very early next year. And we're hoping to share those results at CROI in February next year, February, March next year. And so that will then give you that information, whether we need to dose adjust. But when you look at the data I showed you from the NIH study, based on only 4 patients, but that data would suggest we possibly don't have to dose adjust. But our data, which is going to be done with many, many more patients, will give us a definitive answer. All right, before I hand over to Nicole, anybody who's dialed in, do you have any questions? There's someone online wanting to ask.
Hold on, they're all muted because they were.
So,
Yeah, go ahead.
yeah, all right.
Meaning, if you wanted to give where we're using recency testing. Recency testing
I think
is a platform that's already been set up and we'll add some more to that.
Sorry,
Right.
I can't hear you.
Sean, go ahead.
Sean?
Oh, no, I'm sorry. I'm sorry. Forgive me. I'm muting myself. I thought I was in.
Okay.
Okay.
Does anybody else online want to ask a question? All right, there was another question over here. Yes.
My question is with regard to women, particularly looking at the safety of rifampicin to pregnant women, and knowing well that in terms of family planning in countries, is that the women tend to know it's a very small population that would likely to know when they are to become pregnant, and how we apply that now for prevention.
Yeah, thank you. That's a very important point. So the rifamycins also influence the oral contraceptives, so the hormonal contraceptives, both oral and the injectable forms. And of course, women that are on dolutegravir now need to be encouraged to be on adequate contraception. And so the question is, does giving rifampicin or rifamycin-based preventive therapy potentially influence hormonal contraception? And so that's a really important question. Thankfully, the ACTG has just completed a trial evaluating with a depot preparation in HIV-infected women. And that's with, not rifampicin, that is with rifampicin. But nevertheless, it will give us an answer that will give us information that we can then use to model. But really, it looks at the dose and the frequency of the depot product. So, either we have to increase the dose or we have to increase the frequency of the injections. Those results will also likely be presented at CROI next year. So, really important information that we're going to be looking to inform women in terms of their contraception. Amita, do you want to comment on that? Oh, hang on, I've got to unmute you. Okay, you can talk.
Yeah, Kevin, no, I think you've summarized, I think with the current state of data, the contraception and use of rifamycins generally are, we have the data from the ACTG study, but I think that generally with a lot of the ARVs, particularly things like dolutegravir being on the block, women are encouraged to either not be on it or be on at least 2 forms of contraception. So I think we have data for some of the older regimens with the efavirenz, but I think it'll depend on what are the current guidelines for ARVs in each country for how best to do the contraceptive guidelines. And for rifampicin, which has more potent rifamycin activity, we really don't have as much data, if any.
Great, thanks, Amita. All right, I'm now going to hand over to Nicole, who's going to talk us through the pediatric data.
This doesn't do what it's doing all week with me. Make sure these guys can see it. Okay, you're up. Awesome. Okay.
Hello. So I'm Nicole Salzar. I work at Johns Hopkins. I'm pediatric ID, working with the IMPAACT4TB group. I have a lot of slides, some of which we've seen a lot of today, and so I'm going to flip through those somewhat quickly. Yeah. Click one.
About like,
Okay. So we talked about pediatric epidemiology quite a bit. There are 1 million new cases a year. Over half of those are not detected and not reported. Pediatric TB is a top 10 cause of under 5 mortality when you consider its contribution to malnutrition, to pneumonia, to meningitis, and it does cause about 250,000 child deaths a year, the vast majority of which are not diagnosed and do not access treatment. Just to further elaborate on what Gavin was saying earlier about the age-related risk of TB disease, for children under 5, they have a much higher risk of progression to disease than older ages, up to 50% in children less than 1 year of age. And of course, this is not just pulmonary TB, but also disseminated forms of TB, including TB meningitis and miliary TB. There's also an increased risk for adolescents. So that red bar goes up again in kids 10 to 15 years old. We don't really understand why that is, but it's been shown in multiple studies over time. Certainly there's a knowledge implementation gap where only about 23% of children exposed to infectious TB in their homes are initiated on TPT last year in 2017. For our IMPAACT4TB countries, these numbers ranged from very low at 11% to technically greater than 100%, but I think in a lot of these are issues with the denominator and not knowing exactly how many contacts are out there. This is a data from a study we did in the Motlasana subdistrict of Northwest Province in South Africa, where we we implemented a child file and sort of calculated a cascade of care over time. We had previously done household-based contact tracing studies, and so we were able to estimate what we think is a fairly accurate number of estimated child contacts. And what we learned is that in clinics with facility-based contact tracing, with the index case, we only identified about half of the children who exist. Of the children we knew existed, only half presented to the clinic for screening. Once they came to the clinic to be screened, after a lot of training and a lot of support, nurses were able to initiate 96% of those children on therapy. And that's irrespective of how they screened those patients. So this was a trial where we compared symptom-based screening to TST-based screening. And in both methods, the nurses were able to initiate the large majority of patients who presented to the clinic. Of those who were initiated on treatment, only about half completed, about a third completed therapy. If you sort of take how many children completed 3 months, you'll see that that number doubles and increases to about 80% if you count the number of children who came back for at least one visit 1 month later. Certainly there are a lot of challenges to pediatric TPT delivery, which we talked a lot about today. A lot of knowledge gaps with the index case, with the caregiver and the provider, a lot of attitude and perception with the provider and the patients, a lot of issues with access to care, and a lot of treatment-related issues. Just sort of going through, I'm not going to actually go through a lot of the individual steps because we talked a lot about this today, and we talked a lot about the need for community-based evaluation of children and potentially also community-based initiation of care, but at least community-based contact investigation, community-based follow-up. And all of those can help different steps in the care cascade. One thing that does need to happen is in a lot of these countries, children have a road to health card. That's where their information gets kept, and there aren't clinic-based files. And so as programs, it's a challenge to even see how well you're doing, because a lot of that information is not captured at the clinic level. I do want to talk about symptom-based screening for just a moment. So symptom-based screening has been the recommendation by the WHO since 2006. It's in most country guidelines, not all country guidelines, but I think at the clinic level, we're still struggling to implement it, largely because nurses and all healthcare workers feel uncomfortable with children. They're afraid of being wrong. They're afraid of harming the child who appears at that time to otherwise be well. And so what we learned with symptom-based screening in both retrospective and prospective studies is that there is imperfect sensitivity. You will sometimes miss patients who might have a positive chest x-ray, but the patients you miss are patients with asymptomatic hilar adenopathy. And if you go back to natural history studies in the 1950s and before, what you'll learn is that these children actually do not progress to disease. These children, this is actually primary disease. Though we treat with 3 drugs, we do not probably have to treat with 3 drugs. And to be honest, early studies of INH showed resolution of all symptoms with 6 months of INH alone. So, so we may miss things that are currently treated by TB programs as TB disease, but those things may not actually represent TB disease. In our study in a programmatic setting, about 1% of children who were initiated on TB preventive therapy ended up developing symptoms during their 6 months of INH. The vast majority of those children were in the first month or 2 of treatment. One child was a little bit later. We think that the symptom screen does not perfectly identify symptoms. These children may have been pretty asymptomatic at the beginning, maybe had some very mild symptoms, developed symptoms very shortly after initiating isoniazid preventive therapy. These children were all evaluated. They got gastric aspirates. Some of them had positive cultures and experts, some negative, and were diagnosed clinically with TB disease. All of these children were successfully transitioned to TB disease treatment with 3 or 4 drugs, and all of them completed therapy successfully, were asymptomatic at the time that they completed disease. And so it's an important message, I think, for programs and for nurses that, you know, even when they're asymptomatic, when you start TB preventive therapy, children can sometimes and very rarely develop symptoms that should be evaluated for TB disease, but there's no increased risk for the child. They won't develop resistance. The amount of bacteria, it's exactly what Gavin's slide said earlier. And for children, I'll just say that the risk is that much lower because they have paucibacillary TB. They have many, many fewer bacteria in their chest than adults. And so therefore the risk of developing resistance is essentially 0. And so even if you make a mistake and you start a symptomatic child on TB preventive treatment, you really should not be able to develop resistance. Just gonna go here. And just as a reminder for everyone, even though we have these weight-banded dosing charts on every wall in every clinic, in our study, 25% of recorded INH doses were actually incorrect for the child's weight. And so even just very simple training about how to read a dosing chart is very important as we roll this out. Also, the number of pills is often not provided well. So you know, in INH, in adults, you get 1 pill a day. In children, they come in 100 milligrams, and you can have a dose that ranges anywhere from 25 to 300 milligrams. And so many nurses would just give 30 pills no matter what the child's dose was. If it was 2 pills a day, they would give 30 pills and expect that, and then tell the patient to come back in a month, not realizing that that patient needed 60 pills and that inevitably that patient would end up defaulting over the course of that month unintentionally. So just to go over some of the data for rifapentine in children. So just see here. So this is the adult dosing. So these are the levels of rifapentine in blood when adults are given rifapentine. These are the doses when children received crushed rifapentine, and these are the levels when children received whole rifapentine. So children do absorb more rifapentine when you give it whole than when you give it crushed. However, at these dosings that we have now from study 26, children's levels are when you crush the pills, although less is absorbed, is very similar to what you see in adults. And so truly, whether you crush the pill or whether you take the pill whole is fine for children. Obviously, we are eagerly anticipating the data from TBTC study 35. We want a dispersible tablet. We want it co-formulated. We want it to taste better. We can't wait for it to come, but there will be, I would say, at least 2 years before we have both the data and the actual formulation ready to go. And so in the meantime, we do not have dosing for children less than 2 years old. We have dosing for children 2 to 15 years old. These are data also from study 26, which showed in children 2 to 12 years old with the dosing that I showed in the previous slide, where 3-HP was non-inferior to 9 months of isoniazid. There were 3 cases of TB that were detected out of 434 in that 9 months of INH, and 0 in the 471 children who took 3-HP. I wanted to just show a little bit of data on 3HR because that's, I think, for the younger kids, what we're really considering, or what many programs are considering instead of 3HP. 3HR, and this is a meta-analysis of 3HR. These are all adult studies, and it was non-inferior to 9 to 12 months of isoniazid for TB preventive therapy. There was a subsequent study after this that did look at both 4HR and 3HR in children, which was generally thought to show that 3HR was non-inferior to 9 months of isoniazid. There was improved adherence. 89% completed 3HR versus 65% of kids who were taking 9 months of isoniazid, and side effects and hepatotoxicity were similar among the 2 groups. This is showing 3HP versus 3HR versus 9 months of isoniazid. Efficacy there, both 3HP and 3HR are non-inferior to 9 months of isoniazid. Completion rates are much higher for 3HP and 3HR and fairly similar to each other versus 9 months of isoniazid. There are very few hepatotoxicity events in any group. So there are many fewer side effects and many fewer events of hepatotoxicity with any pediatric regimen compared to adults. And then the number of doses is vastly different, 12 doses versus 90 doses versus 180 doses. I did want to just show one set of data that throws a hitch in both 3HR and 3HP. And that's how rifapentine, well, actually we don't know rifapentine, how rifampicin lowers nevirapine levels, and specifically with prophylaxis. I know nevirapine is not commonly used in HIV regimens in children, but it is commonly used in the first 6 weeks of life as prophylaxis. And here rifampicin does reduce nevirapine concentrations. It's not known what concentration of nevirapine is required to prevent mother-to-child transmission. We know rifampicin reduces nevirapine concentrations, but the number of children in this study was not sufficient to tell us whether or not it decreased the efficacy of nevirapine. And given the fact that we're talking about mother-to-child transmission, the recommendation by these authors, they felt that it was prudent to avoid rifampicin-based TB prevention regimens while on nevirapine prophylaxis. Overall, this applies to a small number of children. We're talking about children who were exposed, maybe mom developed TB during pregnancy, or children as newborns who are exposed in about the first month of life. So it's a very small number of children that we're talking about, but both rifampicin and very likely rifapentine will lower nevirapine levels, and it's unclear whether or not that would cause increased HIV transmission. And so just as a sort of summary, 3HP is efficacious, it's tolerable, it has much higher completion rates. There's increased tolerability, although the number of pills in each one of those doses may appear high. It can be crushed, it can be given with food, it can basically be given with anything. In the US, I tell people it can be yogurt, it can be applesauce, it can be ice cream, it can be anything your child likes. It can also be porridge, it can be pap, it can be whatever you want. The higher fat foods are better. It helps with the absorption of rifapentine, but really it can be dissolved and given with anything. Certainly, the complexity can hinder implementation. We would much prefer to be able to roll out sort of 3HP in children 0 to 5 and really 0 to 15 all at once. But we don't want to limit it and not give it to anyone while we're waiting for these kids who are 0 to 2 years old. I think parents can be nimble. I think parents can understand that younger kids may need different doses or different drugs than their older children. Certainly in HIV programs, we've been giving children different regimens than their mothers for the last decade, and that hasn't caused a tremendous amount of confusion. I do think providers and programs will need to be a little more nimble than they may like to be, and we can talk about how to do that. So 3HP is a better option for TB prevention than 3HR in household child contacts 2 to 15 years. We're going to pilot TPT in all of these countries. We want to do it in children 2 to 15 years old while we await the data for children under 2, and we acknowledge the complexity surrounding the rollout, but do anticipate simplicity in the future.
Can you hear me? Yeah, this is Lawrence. I just wanted to talk about identification of pediatric TB contacts/activities. So, for example, now we see a lot of heterogeneity in identification of the numbers that are identified in, let's say, cities that have central hospitals that have a lot of specialists around the health system as compared to other sectors that poor resources in terms of specialists or medical doctors and use lower cards of clinicians to actually deal with pediatrics. In those particular problematic settings, what would be your advice to how to mentor lower cards clinical scale to actually be able to be confident to screen pediatrics, to identify pediatrics that require to be treatment or require to be protection, because that actually is a very, very huge challenge in terms of finding the numbers of pediatric contacts and putting them on the right information.
Yeah. So I think there'll be a lot more knowledge that comes out of the CAP TB project, UNITAID project, which I'm not personally a part of, but I think we will have more knowledge on the best way to mentor nurses. In my experience in South Africa in this study, The mentoring nurses was incredibly important. Messages that were particularly important are there's a low rate of adverse events and hepatotoxicity in children. If you get it wrong, you can't really harm them. You might need to switch them to TB treatment about 1 in 100 times, but you haven't caused them to have MDR TB. You haven't caused them to become very, very sick. It simply requires a switch in regimen. And probably those two messages alone were hugely important for the nurses, especially when considering how uncomfortable they are with children in general, and asking those symptom questions. And then we did also provide a lot of mentoring over time. So they had, like an initial training, and then every 6 weeks at the very beginning of the study, and then every 3 months throughout the 18-month therapy, I had a one-on-one session with each of the TB nurses. And that actually seemed to help, because they were able to say, okay, well, I'm trying it out, doc, but I have these questions. And so I think mentoring over time is important, and not just, going into a facility, giving a training, and then expecting a lot of change.
I guess that there was a overdiagnosis of pediatric TB. Correct me if I'm wrong. If that's the case, though that this may not be the objective of the study, were you able to quantify the percentage?
Yeah, so there's no gold standard diagnosis for pediatric TB. So we'll never be able to say if any one particular individual was overdiagnosed or underdiagnosed. Well, we can say they were underdiagnosed eventually. I think most people who work in pediatric TB will tell you overdiagnosis is good. When you overdiagnose, you reduce mortality. We can't perfectly know who does and who does not have TB. I've heard people say, so you start 3H, or you start RHZ. It's kind of just really, it's 3-drug preventive treatment, right? In kids, it's better to overdiagnose. You will miss cases if you don't. And so lowering our thresholds and diagnosing more children with TB will overall lower your pediatric TB-associated mortality. And until we have a more perfect diagnostic ability for young children, we won't be able to change that. Now, hopefully through Speed TB and all the work that's going on, we will have better ways to diagnose children, but right now we don't. And in the immediate future, I would say overdiagnosis is safer than underdiagnosis.
That's a great job. I know.
Just from the studies on page P in children, what was the pill burden for children? I understand that you could crush, whether you crush or you give tablets in terms of absorption, it's not really that much of an issue. But I'm just thinking here, with the current regimen, where we have a fixed dose combination, which is child-friendly, but we add tablets as well. Now, what we're picking up is there's a lot of challenges in terms of guidance, advising, actually crushing the tablets and ensuring that the children take that. And if the pill burden is high with 3HP, practically, how would that be administered to the children? Would they, for example, stagger the number of tablets? I don't know how many they are. Stagger them, or they have to give all the tablets at the same time? Because that's the guidance that I think we would need to provide.
Yeah. So the number of pills is going to depend on the weight of the child, but the same is true for 3HR or for INH. The number of pills, I actually don't know the number of pills for 3HR. It will be a higher number of pills INH, but you give it once a week and not every day for 6 months. And so if you consider total number of pills that you're going to give a child, it's going to be much less with 3-HP than with 6-H, right? At any one given time, you might give a little bit more medication, but I think it's easier to do that 12 times than it is to do it 90 times or 180 times. Not all parents will probably agree with me. Every kid is a little bit different, but I think for the vast majority of children, it's going to be easier to do that 12 times than it is to do that 180 times or 90 times with 3HR. It was, you know, Gavin went through the sort of tolerability and how well children are accepting the medication and taking it. I don't know that I have any further experience to add from the U.S. perspective. It's been fairly well tolerated, and the pill burden has not been as big an issue. I think one thing I particularly always share with families is, you're going to add it to a bottle, don't add it to a full bottle, because what if your child then doesn't take the full bottle? Add it to a small amount, let them finish that, and then sort of replenish the bottle or whatever food it is you've put it in. But that has not been what we've seen as the issue.
If there's any phone questions.
Anyone on the phone?
Let me see. Oh. Asked in chat. Oh wait, there's one. Hold up. Nothing. Okay.
Sounds good.
Okay. So thanks. I don't need this really right now. Thank you. Yeah, thank you both, Gavin and yeah, Nicole. I think this is exemplary of what we wanted to do. Take advantage of the TB meeting, of course, but also continue doing this for this project going forward, because it's very helpful to have these updates and how we're going to do them with webinars or things like that. We even were hopefully going to consider, we're mixing the recording that was done with the PowerPoints, and then we'll post them on the IMPAACT4TB website if most of this information can go public. And then we continue following up on some of the key points and questions going forward, just to clarify, especially when the updates from trials come next year at CROI and pieces like that. So this will be up, give it a week or so, because we have to sync the audio, but otherwise everyone will get these slides, because I know some people are pinging me to ask for them. Okay, and for now, we didn't have supper, as Gavin had stated. If you're on a diet, it's supper. So sorry for those on the phone that don't get to eat, but there's some tidbits of stuff over there that you can grab before you leave, so you have enough energy to get on your bike back to your hotel or wherever you have to go. Okay, thanks so much for attending. I appreciate it. Okay, thanks everyone on the phone as well.
Thank you. Bye-bye.
Bye.
Yeah.